Hi, my name is Alyssa Everett. I did my case study on acute calculus cholecystitis, which is acute gallbladder inflammation. Background information: she was a 29-year-old female with a past medical history significant with dyslipidemia, type 2 diabetes, mellitus, and she presented to the ED complaining of abdominal bloating, nausea, vomiting, and sharp upper right quadrant pain. The pain began the night prior to finishing her dinner. She described the pain as constant and unbearable. She rated it as an 8 out of 10 in severity. She says the pain was not getting any better or any worse, and that she was unable to find any relief. She's never had any similar symptoms before. After physical examination, it was determined that it was acute calculous cholecystitis, and she would require a cholecystectomy. Some history of present illness. Her initials were SN, age 29, female, waitress, single, lived at home with one cat, drinks 5 to 10 drinks a week, social smoker. She was oriented to personal time and place. She was overweighted, stated that she normally eats fast food or she normally eats bar food. Her allergies were Benadryl, which caused facial swelling back in 2000, and Dilaudid, which caused nausea back in 2010. Her ASA was 2. She received 2 grams of Ansef preoperatively. Some signs and symptoms that she presented with into the D were experiencing nausea, vomiting, bloating, and cramping, along with upper right quadrant pain, fever. Her vitals were 142/85. Her heart rate was 71, respiration 17, SpO2 98, temperature 101.6. Her BUN was 12. Her creatinine was 1.6. She had a pretty high blood sugar of 151, and her white blood cells were elevated with 11,500. Upon physical examination, cholecystitis, which is inflammation of the gallbladder, which affects the gallbladder and the digestive system. The gallbladder sits below the liver and aids in the storage and secretion of bile in our body. Some general information: she was moderately acute distressed while laying supine. Her eyes were perla. Her AAO was person, place, time, and situation. Lymph nodes were lymphadenopathy. Skin was 2+ skin turgor, no rashes. Skin was warm and dry to the touch. Her chest was RRR, no MGR, no JVD, no pruritus, strong pulses bilaterally. Her lungs were clear to oscillated bilaterally, no use of accessory muscles, no wheezels or crackles, and there was no signs of cyanosis or clubbing. Our upper extremities were 5 out of 5 for strength. In all extremities, normal range of motion, and no edema was present. The abdomen was mildly distended. She did have mildly hyperactive bowel sounds, right upper quadrant tenderness to palpation, and a positive Murphy sign. What provoked it was moving and or walking, aggravated it, along with eating fatty foods. The quality of it was sharp and nauseating. The region was the upper right quadrant. Severity was 8 out of 10. Timing, she stated it was the night before, hourly accompanied with signs and symptoms of cholecystitis. Past medical history: obesity, depression, dyslipidemia, type 2 diabetes, and hypertension. Past surgical history: she's had a C-section and tonsillectomy. Her medications were sertraline for depression and Lispro for the type 2 diabetes, along with a multivitamin. Her family history included CAD, hypertension, and diabetes. Signs and symptoms: textbook manifestations, which include severe upper right quadrant pain, center abdominal pain, abdominal mass, positive Murphy sign, tenderness to the abdomen, nausea, vomiting, and fever. The biggest concern with someone that has cholecystitis is that it could rupture and then the person will become septic. Some risk factors for cholecystitis include gallstones, physical inactivity, low fiber or severe illness, obesity, high estrogen levels in younger females. This does develop in about 6 to 11% of patients that are with symptomatic gallstones. So diagnostic testing for cholecystitis include LFT tests, RUQ, which is your upper quadrant ultrasound scan, your FBCs, your C-reactive protein, abdominal CT, reveals imaging of the gallbladder, a HITA scan, an aminodiactic acid scan. The scan is used to track the flow of the bile from the liver through the gallbladder into the small intestine. An abdominal X-ray, abdominal MRI, and endoscopic ultrasound, all of which reveal imaging of the gallbladder ducts and tubes. My patient was diagnosed through hands-on examination along with HITA, full lab workup, MRI, and a CT of the abdomen. Pathophysiology. Acute calculous cholecystitis is an inflammation of the gallbladder that occurs in the setting of the cystic duct obstruction. The gallbladder is located inferior to the liver and stores and secretes bile, a digestive fluid utilized in the breakdown of fats. When the cystic duct becomes blocked, trauma is caused to the surrounding area, and the combination of cystic duct obstruction and the irritant, often lithocysin, which is a component of the bile, causes an inflammatory mediator to be released from and propagate inflammation in addition to the inflammation caused by the obstruction. Some biological manifestations. The purpose of the gallbladder is to hold bile that is then secreted into the small intestine for fat breakdown. Physical manifestations. The most common cause of cholecystitis is due to gallstones blocking the tube that leads out to the gallbladder where the cystic duct is located, causing an obstruction. When this happens, the bile then backs up, causing the gallbladder to flare up with an acute inflammation. Some other common causes of cholecystitis may be a bile duct complication, serious illness, infection, cancers, and tumors. Left untreated, it may be deadly or even life-threatening if it were to rupture. Complications may also include a torn gallbladder as well as death to the gallbladder tissue, necrotic tissue. Treatment for the disease. Surgical removal of the gallbladder is the most common and preferred method, which is laparoscopically performed, where they make 4 small incisions and enter into the abdominal cavity through trocars using a telescopic visualization to locate the gallbladder. The abdomen is then inflated using carbon dioxide for a clear view. If the surgeon is unable to access and remove the gallbladder laparoscopically through one of the small incisions, the abdomen then is deflated and a large incision will be made and the gallbladder will be removed that way. The patient should be free of pain, swelling, infection, redness, and should maintain a normal temperature within 48 hours post-op. Some of the other common treatments may include fasting, IV therapy, antibiotics, pain meds, and surgery. For my patient, all of these were implemented and the surgery was required to resolve the blockage. Some preventive measures that you can do is losing weight at a controlled rate. Maintaining a healthy weight. Being overweight is one of the most common risk factors for gallstones. A healthy diet is definitely recommended, avoiding foods high in fat and low in fiber, and this has been directly related to cholecystitis, so that's why consuming foods such as fruits, whole grains, veggies is recommended. Patient outcome impact on practice. The patient will receive a referral to a gastroenterologist and nutritionist, as well as a follow-up with the PCP in 2 weeks. For me, the last time I saw my patient, it was when I was after surgery. At this point, I took the patient to PACU and where they were waking up from anesthesia. All of the patient's vitals were stable. Her temperature had gone down from 1.6 to 101.3. The surgery went very smoothly, laparoscopically, and the gallbladder was then sent to pathology in permanent for testing. In this particular case, I discovered that all gallbladders are dramatically different size, regardless of the body size. For me working in the OR, this is a very common procedure that we see daily. Thank you for listening to my case study on cholecystitis.